Okay. So good evening, everyone, and thank you for being with us. Sorry for the modification of the timing of the presentation based on our esteemed presenter schedule, very, very busy schedule. And to go without due delay, tonight we have a very special, respected colleague, Dr. Maha Alsindi, our eminent medical oncologist in Bahrain Oncology Center. She is going to speak about the basics of systemic therapy in ovarian cancer. I asked her to be not to go in depth, not to go in details. This is something for the gynecologist and for the general gynecologist. So we'll try to understand what is the role of systemic therapy in ovarian cancer. Thank you, Dr. Maha, for giving us your time. I'll put Dr. Tarakan as a panelist too, so that he can moderate and he can ask and whatever. Dr. Tarakan, thank you for being with us, Dr. Tarakan. Now you are sharing and you can speak anytime you want. Okay, and the floor is yours, Dr. Maha.
Thank you so much, Dr. Basil, for your invitation to speak. I'm really happy to inform just our surgeons of what we do, a little bit of what we do once patients are referred to us. So I'm going to be talking about the basics of systemic therapy in ovarian cancer. And what are some of the recent updates and sort of ground-changing updates. I'm sure a lot of the surgeons or our colleagues with us know that the main treatment is platinum chemotherapy. So I'll start with a little bit of a background. We know that most patients with ovarian cancer, they present at advanced stage, and most of them relapse even after the first-line multimodal therapy. There is over 300,000 women diagnosed with ovarian cancer. That was the statistics in 2020. And approximately 60% will present at stage 3 or above, unfortunately. 70% of women would relapse within the first 3 years after treatment. And the 5-year survival for newly diagnosed ovarian cancer is less than 50%. So less than 50% of the patients that you see are diagnosed will actually make it beyond 5 years of diagnosis. So there is significant need to improve our first-line therapy for women with ovarian cancer. So there has been, again, a lot of progress and some good news over the last while. We know that mortality has reduced by 40% due to the advent of new therapy. And you will see here that it started to reduce in 2013. And we'll talk a little bit about why is that. We know that the incidence is decreasing. However, the prevalence of ovarian cancer is increasing worldwide. So, and we know that ovarian cancer is a disease of relapsing and remitting. So we know at the beginning of diagnosis, the patient first undergoes debulking surgery, he gets chemotherapy, then followed by maintenance. And you see that period becomes shorter and shorter with each time as patients become, let's say, more resistant to therapy, or they become, once you become platinum resistant, that period of progression becomes shorter and shorter, unfortunately leading eventually to supportive care, and eventually patients succumb to the progression of their disease and death. So there has been a lot of new exciting changes in ovarian cancer, starting with some of the new modalities to treat patients, other than, we said that the main treatment for many years was platinum, carboplatin, Taxol. And then we started looking at anti-angiogenic drugs like bevacizumab or Avastin. These are medications that are anti-vascular endothelial growth factor that prevents. What happens in cancer is that usually cancer will acquire new blood vessels, and ovarian cancer is known to acquire new blood vessels. So these medications, this anti-VEGF, which is Avastin or bevacizumab, will block these receptors and will try to kill off the blood supply to the tumor. And then also there is really the new groundbreaking change that really had made a huge difference in ovarian cancer are PARP inhibitors, and we'll talk a little bit about that. In my talk today, I will not talk about immunotherapies and new targeted agents such as ADCs. However, we can look at these further in next sessions. So like I said, what we try to do and we have tried to achieve is that when we treat patients, we try to push them into this maintenance phase, giving them maintenance therapy to try to prolong that time where they are progression free. So we knew that we had in 2003, we knew carboplatin, paclitaxel, that was the backbone of therapy. Whether depending on the stage, and like we said, the majority of patients will be diagnosed with a stage 3 or 4 disease in which they will receive either neoadjuvant or adjuvant chemotherapy, and they will get 6 cycles, and then we used to just observe these patients. But in 2011, we saw the first paradigm shift with the approval and studies that confirmed the benefit of anti-angiogenic drugs like bevacizumab, which improved progression-free survival in comparison to chemotherapy alone. And then in 2018, we saw the second paradigm shift. We started realizing that patients with ovarian cancer, they have high-grade serous ovarian cancer, and the majority of these patients will have either germline, which means inherited in the blood, BRCA mutation, or somatic in the tumor, BRCA mutation. And these patients are very sensitive to drugs called PARP inhibitors, and I'll talk about this later on in my trial. In 2019, we started combining these two modalities together. So combining PARP inhibitors along with anti-angiogenic drugs that will give you the better or best maintenance approach for patients. So again, this was the first paper that came out from Boston that looked at the tumor angiogenesis. And always in oncology, we try to understand how do cancers try to evolve. And there is a really nice paper called The Hallmarks of Cancer for anybody who's interested. And this paper talks about how cancer develops. And one of the methods of cancer survival and development is the, like we said, acquire of angiogenesis, which means new blood vessels. So cancer can make their own new blood vessels. So if we think about just briefly looking at the trials that looked at the addition of bevacizumab, which is an anti-angiogenic drug, there have been 2 major trials, the GOG 0218 and the ICON 7. Little bit difference in terms of the inclusion criteria. The GOG 0218 looked at patients who had untreated ovarian, primary peritoneal, fallopian tube cancer who are stage 3 optimal macroscopic disease or stage 3 suboptimal debulking or stage 4. These are patients who were randomized into, as you can see here, receiving chemotherapy, which was again at that time, this was the standard of care, carboplatin, paclitaxel, carboplatin, paclitaxel with bevacizumab just initially and then nothing, or carboplatin, paclitaxel along with bevacizumab with maintenance treatment then for 16 cycle, which approximately takes you up to almost 15 months. And then the ICON 7, again, which looked at the same thing, stratification, just a difference in the dose and the number of cycles. And these include patients who were debulked to less than 1 centimeter. And then they looked at different stratification, patients who were stage 4 or inoperable, and when did they start the treatment. And what did we learn from this trial? Just to get you, these trials looked at using, like we said, anti-angiogenic drugs at the front line. And we can see here that if you take, so this line is bevacizumab throughout, these group of patients end up doing better. This is their progression-free survival. So if we compare patients on a placebo or patients who receive just chemotherapy, this is their progression-free survival, 10.4 months versus 13.9 months with a benefit of 3.5 months and a hazard ratio. So there is the reduction on the risk of death of almost 30%. And here, again, this is the ICON 7, and we can see this is just the chemotherapy, and this is the bevacizumab patients. And we know that, we see a benefit here of approximately 2.4 months. So patients on the bevacizumab arm did better than patients who just received chemotherapy. And this is they continued for 15 or 18 months, depending on which trial. So they looked at the subset analysis. So is there a subgroup of patients that benefit? Let's say, is low-risk patient will benefit more or high-risk patient? And who do we mean by high-risk patient? So high-risk patient were patient who was stage 3, debulked, but they had macroscopic disease left, so more than 1 centimeter, or they were stage 4 initially. So we see those patients do benefit. And also, even in patients who are stage 3 with less than 1 centimeter macroscopic, they still benefited, as you can see here, with bevacizumab throughout. You can see similar benefit in comparison to if you start only bevacizumab during chemotherapy and then you stop. So for patients who are diagnosed stage 4, stage 3, even if they're optimally debulked or debulked with residual disease, the addition of bevacizumab improves patient progression-free survival. And here we can see this is the overall survival. We can see that the overall survival is unfortunately negative in this trial, and that's why you might see some regulatory difference between countries. Some countries, they don't approve it because of the lack of the overall survival data. You can see here, but if we look numerically, just we see the events are less in the bevacizumab arm. And then this is the, this is the final, again, overall survival. We can see here in the stage 4. So in patients who are high risk, this is for everybody. The final analysis in all the patients, whether they're stage 3 or stage 4. But then they looked at another subgroup. So patients who were stage 4 in the beginning at diagnosis, those patients actually had the highest survival. And in this subgroup of patients, you see an overall survival benefit. You can see here, again, this is the line of bevacizumab and chemotherapy. And continuing bevacizumab in the maintenance, look at the median overall survival, 42.8 months versus 34 months. So you're gaining approximately 10 months of, at least 10 months of benefit if you add bevacizumab. And again, here it's very clear. You can see the red line is the addition of bevacizumab, and the blue line is just chemotherapy. And if we look at the median overall survival, so we can see here it's 30.2 versus 39.7 months with, again, hazard ratio of 0.78, so a reduction in the risk of death of approximately 22%. So again, this, of course, translated to the guidelines in patients who have complete response or partial response post-primary treatment. Again, we add, always if you started with bevacizumab, you try to continue, and we try, especially for patients who are, let's say, stage 3 high risk, so with residual disease, or a stage 4, because there is overall survival benefit. So the other thing that really made a difference, if you remember going back to just this slide, is the second paradigm shift came in 2018. This was when this trial, or we started looking at just some of the molecular background of ovarian cancer. So the TCGA, which was, they looked at all the genes in ovarian cancer, and they found that patients with ovarian cancer, especially high-grade serous ovarian cancer, have defect in homologous recombination. What do we mean by that? I know this looks very confusing, but I'll try to simplify it as much as I can. So normally we have, when we damage our DNA, there's 2 ways to repair our DNA. You can repair our DNA using the base excision repair, if you remember from days of physiology, or we can repair our DNA using the double-strand base repair mechanism. So these 2 main mechanisms are the mechanism in which if our DNA gets damaged, we fix them. So the base excision repair involves an enzyme called PARP, which tries to join the two ends together. If you have a double strand repair, you are dependent on two ways of repairing: the non-homologous end rejoining, so you join the two ends but they're not attached, or the homologous recombination, which you attach them. And this mechanism of double strand repair requires BRCA1 and BRCA2. BRCA1 and BRCA2 are the genes that are involved in homologous recombination or double strand repair. So think of these two ways, and I'm going to talk about how you, for example, if you have a deficiency, for example, patients who have BRCA1 or BRCA2 mutation, they are deficient. They cannot repair double strand DNA break. So they already cannot do, by inherently, they cannot fix double strand repair. So they depend completely on DNA single strand repair mechanism. When we target PARP, the enzyme, with medication, drugs that inhibits PARP inhibitor, you get something called synthetic lethality. You cannot fix any damage that happens to your cell because you're already deficient in this pathway, and then this pathway is blocked by the drugs that we give, which are PARP inhibitors. So the DNA cannot damage. You have signals that tell the cell you have to die because we can't repair you, and that causes cell death. Okay, so, and we knew from, again, the TCGA that most ovarian or high-grade, especially serous ovarian cancer, they have deficiencies in this pathway, which is the homologous recombination repair pathway. They have genes that are affected and they can't, or they have a BRCA mutation that doesn't allow them to repair the double-strand DNA breaks. So again, how does PARP inhibitors work? And like you said, when we give PARP inhibitors, the PARP gets trapped on the single-strand break. This causes more breaks in the cell. In a normal cell, you will repair it via the double strand or the homologous recombination pathway. However, if your cell has homologous recombination deficient, this will cause that accumulation of genomic mutations, and it will cause cell death. So I hope that this is clear enough. So why is this important? It's important because the majority of the patients, as you can see here, we have some patients with ovarian cancer, 50% will have homologous recombination deficient. Okay, so 50% of ovarian cancer were unable to repair the mutations by homologous recombination. And out of these, 15% will have germline mutation. This is inherited. So it's inherited in their germline genes, passed from one generation to another. The other 25% in the red circle will have acquired. So either somatic, which means in the tissue, not in all the blood, not in all the cells, only in the tumor cells. And then the other 50% will have HRD. They might not have the BRCA mutation, but they will have other genes that are involved, or other mutations that are involved in homologous recombination. So now the important thing is, how do we know? How do we test? Us as physicians, when you have a patient, how do we test for these? When we look for, we can do two things. Either we do a blood test, which looks at the germline BRCA mutation, because we're looking at all your, whether in all the cells you have BRCA mutation. This is one way of doing it. The other way of doing it is looking at, we're not seeing which enzymes are deficient, we're looking at the effect. So we're looking at the effect, which is, the effect are these. They look at what we call scarring on the gene. When they look at what's something called the genomic instability test, which looks at these three things: loss of heterozygosity, telomeric allele instability, and L, the large-scale state transitions. So basically, we're looking at, does the cell show that there is an effect of a homologous recombination deficiency? Just to give you the short answer, how do? We do it by tests. We test the tumor tissue. There are two approved tests, either the My Choice test or Foundation, which looks at, and then we look at the number. There is a number. Beyond that number, that means you are HRD, which means homologous recombination deficient, or proficient if your test is below a certain cutoff, and that will depend on which test you do. Okay. So in our institution, for example, in Bahrain Oncology Center, we send first for HRD, and if we can't find an HRD, then we send for germline mutation, or sometimes we do them together. If there is a strong family history, we look at germline. If the germline, which means all your cells have a BRCA, then we don't test for HRD. However, if the BRCA germline is negative, we test the tumor for HRD. As we said, 50% of patients will have mutations in their HRD. Why is this important? Because, as we mentioned, we can target these with PARP inhibitors. So like I mentioned, ovarian cancer is characterized with multiple relapse. Patient first gets first-line chemotherapy, plus bevacizumab and surgery, and then usually they have a median platinum-free interval of 12 to 24 months, and then they start to recur again, and then depends if they are platinum sensitive or not. So usually we say if they're platinum sensitive, the cutoff is 6 months. Really, that's the magic number. So if they're more than 6 months, we re-challenge again with a platinum and another agent. And like you said, it's like you can see, it becomes shorter and shorter and shorter with time. Unfortunately, most patients will end up having complications such as bowel obstruction, ileus, and then unfortunately they pass away when their tumor becomes platinum resistant. So once the disease relapse, it's largely incurable. So first line, advanced ovarian cancer is the optimal setting in which we try to achieve a potential cure. There is no point of hiding your best guns for later, as these patients recur over and over again. So what we try to do in this setting, we try to optimize, we try to achieve an area where, or a time where you can see here, we achieve a complete response. And then with maintenance therapy, we try to eliminate any minimal residual disease that you can see, or possibly, that is circulating in the blood. So again, this is the sort of the outline of the majority of the trials that in the maintenance setting. So you give chemotherapy, you do surgery, then chemotherapy, patient response, then they are, randomized into maintenance PARP inhibitor or control, which is a placebo for a duration of period. And then the outcome is looking at the progression-free survival of these patients. So this was the first study that was done. And I remember in 2018, when this was presented, people stood up and were clapping in the hall, because this was the first trial that made really a difference, and you're going to see why now. This included patients who were newly diagnosed stage 3 or 4 high-grade serous or endometrioid ovarian cancer or primary peritoneal fallopian tube. They had to have germline, which means in the blood, all the cells, or somatic in the tumor tissue BRCA mutation, underwent cytoreductive optimal debulking surgery, and then they had to be platinum sensitive. They had to have chemotherapy and didn't progress or have a partial response, and then they were randomized into doing nothing or putting patients on olaparib, which are PARP inhibitors, for 2 years. And then the primary endpoint of the study was the progression-free survival, and you can see here secondary endpoint. So 2 years of treatment if no evidence of disease, and then they stopped. So as you can see here, we never see these curves in ovarian cancer. This was something that was, astonishing. So as you can see here, the hazard ratio of 0.3, so you are reducing the risk of death by 70%. In comparison, look at patients on just observation and how poor they did. In comparison to patients who are on olaparib at 3 years, 60% were alive versus 30% were progression-free at 3 years on the placebo. And again, this was the 5-year update. And you can see here, you see, even from early on, there is separation of the curve. Patients end up doing better. So look at the olaparib group, 56 months versus 13 months. So patients are living, you're adding 3-4 years to their life with olaparib if they were BRCA mutant. And this was the final overall survival that was presented here. Again, we see similar benefit. We don't see any detrimental effect. And even though we see a survival benefit, patients still, I mean, even with a crossover, which means that patients who progress ended up having olaparib, will still be a benefit. This tells you just the magnitude of benefit that this treatment causes. And you can see here, this is the events in the placebo and the olaparib arm and the median OF has not reached versus 75 months in the placebo group. So then there were many PARP inhibitors that came. Niraparib is another PARP inhibitor. And again, it is very similar. All these trials are very similar in terms of design. The difference is that with the PRIMA trial, they didn't look at any biomarker. So if you remember, the SOLO trial included patients who are only BRCA mutation. This trial said, you know what, if you were platinum sensitive, we're going to give everybody niraparib as long as you are platinum sensitive. And again, here we see that this is the primary endpoint, which was progression-free survival in the patients who have HRD positive. So they included all HRD positive, not only BRCA mutation, but all HRD positive, which again, if you remember, this is the test that we do on the tumor tissue. We see a hazard ratio of 0.43. Again, 57% reduction in the risk of relapse or death with niraparib, which is a PARP inhibitor. You can see here 21 versus 10 months. So you're doubling patients' PFS. And again, this is in the overall population and everybody. If you're platinum sensitive, you can see here, this is the overall median PFS. So again, they looked at this subset analysis really. We're trying always in oncology to see which group benefits the most and which group doesn't benefit. So we're not causing extra toxicity to patients. So if we look at the patients who are HRD, here we can see HRP proficient. We don't see any difference in the overall survival. So again, the overall survival results for all pre-specified biomarker-defined subgroup was consistent with the overall population. So we don't see any detrimental effect in this subset of patients. And again, this led to later on in 2019, we saw the result of the PAOLA trial, which basically combined anti-angiogenic drugs with PARP inhibitors. So if bevacizumab improves PFS and PARP inhibitors improves PFS, what will happen if we add both? Because there is a lot of research that looked at adding both medications actually improve and causes more cell death. So what they did is that, again, patients were optimally debulked, you know, or had platinum sensitive disease. Along with bevacizumab, they were randomized to continuing just bevacizumab versus PARP inhibitor plus bevacizumab. Again, primary endpoint was a progression-free survival. And this is just the rationale of combining both. So again, this was the first study, the PAOLA study, which again, they included patients who had either upfront interval debulking surgery, platinum sensitive, at least had a three cycles of bevacizumab, and again randomized to olaparib and bevacizumab or placebo and bevacizumab. And again, here we see, again, the combination does better. So giving the patient both, you are reducing the risk of death by 40% approximately. And you can see here the median PFS 22.9 versus 16.6 months. And if we look at the HRD status, so patients who are BRCA mutation, okay, and HRD positive, patients who are HRD positive and a BRCA mutation, and if you remove all the BRCA mutation, so these patients with BRCA definitely benefit. These patients with HRD in their tumor definitely benefit. However, if you are HRD negative, so if you are what we call HRP proficient, you don't have any deficiency, there is no difference. So adding PARP inhibitor doesn't improve anything. You can see the median PFS, 16.9, 16, and a hazard ratio of 0.92, and it crosses the boundary of 1. And this is the overall survival in everybody. And everybody, you can see here the median, the 5-year overall survival rate. And again, if you look at the HRD positive patients, these are the patients that benefit from such drugs. And basically, this is how we have now the guidelines reflect how we can molecularly define certain subtype of population that will benefit from the addition of PARP inhibitors. As you can see here, if they are HR deficient, we have an option of doing niraparib, rucaparib, olaparib. And here, if they are germline BRCA mutation, then again, all of them. And if you see here, they are HR proficient, then bevacizumab by itself. I don't know why. It kind of went all the way back. So again, this is sort of, it tells you have to look basically at germline or somatic BRCA and HRD testing. Ideally, you would do both. So again, these are just putting all the trials together. What are the main side effects of these medications? They can cause some nausea. They can cause some bone marrow suppression, anemia. They do have a risk of hepatic toxicity. Some medication can cause thrombocytopenia. And the main toxicity of PARP inhibitors is sometimes it can increase the risk of myelodysplastic syndrome, so MDS. So what is the key take-home message? That there has been a lot of advances in ovarian cancer, and there is a lot of new opportunities looking at DNA repair pathways. It's important to do BRCA and HRD testing. That's why it's very important for us to get a biopsy before from our surgeons, because if sometimes you give patients chemotherapy and then they had a good response, you'll never be able to know, should I combine all these medications to the patient or not? So it's very important to have a biopsy pre-treatment so that we can do the testing on it. Therapeutic management of ovarian cancer in multiple settings has shifted dramatically, with especially we're seeing overall survival data with the addition of PARP inhibitors and PARP inhibitors with bevacizumab that possibly can cause a cure in the first-line setting of maintenance. So it's very important to introduce PARP inhibitors as early as possible for all eligible patients. And with that, I'd like to thank you, and I'm happy to take any questions.
Thank you so much, Dr. Maha. Really very interesting for us as oncologists, but I don't know how tough was it for our dear friends from General Gynae. So we are open for discussion for anyone who wants to comment or to ask any question. So to summarize, Dr. Maha, we are speaking about the high-grade serous. We are not speaking about all ovarian cancer. We're speaking about high-grade serous, which represents the vast majority of ovarian cancers. There are another stories for low-grade, mucinous, clear cell, blah, blah, blah.
Absolutely, yes.
And to summarize, our backbone is taxol carboplatin. It hasn't changed yet. We have the place of addition of bevacizumab approved by some countries, not approved in some countries, mostly in the adjuvant setting, in the wet patient with heavy pleural effusions or ascites or disease. And then we have this revolution of PARP inhibitors with also type. Yeah. So we have the revolution of PARP inhibitors from olaparib, niraparib, or those PARP inhibitors. And we have now promising tools in the IOs, ADCs, which are still under clinical trials up to my small knowledge.
Yes, we can talk about that in a later setting in terms of
Yeah.
what are the future,
Yeah.
how does it look like? And it looks like we're seeing immunotherapy coming in the platinum-resistant setting. So there has
Yeah.
been a lot of data in the recent ASCO about immunotherapy in the platinum-resistant setting and looking at antibody drug conjugates in the platinum-resistant setting. But I think, again, once patients are really platinum-resistant, it's really bad story for them. The options of treatment becomes much narrower. We're going, thankfully now we have some new medications, but really the benefit is still, or the outlook is quite dismal. So the best chance for patients for a cure is in the first line, is with maintenance therapy. So try to, always know the molecular background of your patient. Try to cure them in the first line setting. And again, you saw the 5-year overall survival. Unfortunately, the majority end up relapsing at some stage.
Great. Thank you, Dr. Mas, so much. There are no questions from the audience. This means you were very clear or very sophisticated. We will know from them later.
Or very confusing.
Yeah, but they must, as I always tell my colleagues, if you are going to do gynae oncology, you shouldn't do the surgical part and then go away when you start hearing PIVA, PARP, ADCs. You can do this. You should know the whole story, not go so in depth, but you should understand because as we say, we should speak the same language. We should know when to refer for neoadjuvant, when to do the surgery. We have to speak about that. What's the genetic BRCA testing? Don't go in so depth if you don't want, but you must know the basics at least. So.
Yes.
By this, mostly we will close the ovarian cancer module for a while. We are returning back to the HIPIC and for other rare cancers, blah, blah, blah. But starting from the next week, I hope we will shift to the endometrial cancer, which will be slightly more interesting for the surgeons I know. And thank you, Dr. Ma, for your time. Really, I know your time is very precious. Thanks for all that.
No, not at all.
Bahrain,
Thank you so much.
Many
Thank
good
you.
faces from Egypt as well. You have like some of the best gynecologists in Egypt, Dr. Mahmoud Meles, the head of gynecology department in Alexandria, Dr. Sham Abu Talib, the director of gynecology unit in Asyut. So you have many audience from Egypt as well as Bahrain.
Thank you. It's always a pleasure to have everybody. I'm so glad to have Dr. Basil with us, and he, after haggling him so much, he agreed to come to Bahrain. And the point of these seminars is to try to bring everybody closer together and get all of ours. And hopefully we can do. We were thinking of doing one session where we're gonna just discuss maybe some cases. It would be nice to do that if that's, I think either challenging from a medical oncology point of view or from a surgical oncology point of view, sort of have our own little MDT discussion.
Yes, of course. That would be great.
Yes.
Thanks for all attendees and see you next Wednesday,
Thank
inshallah.
you.
We will see if it will be
Right.
6 or 7 p.m. We will ask our attendees. Thank you so
Sure,
much.
inshallah. Thank you so much. Thank you.